Hello everyone. Today we'll be talking about chest X-ray cases. So basically what you need to know about this video is this is not an introduction on how to read the chest X-ray. There is another video that I've uploaded that talks more on the introduction on how to read a chest X-ray. So in this video we'll just be talking about a few common cases such as pneumonia, tuberculosis, pneumothorax, and such other cases. So I would suggest if you want to just refresh your memory, you can go to the other video first and then come to this one. However, if you're currently practicing, you can just start with this video. So basically this is a diagram showing a normal chest x-ray. So there are a few things I'd like you guys to note is the number of ribs that you're able to see, the number of posterior ribs. 1, 2, 3, 4, 5, 6, 7, 8. So there should be at least 8 ribs that you should be able to visualize in full inspiration. You should be able to see the trachea, the tracheal bifurcation, the aortic arc. Then one very important thing is the costophrenic angles. I hope you're able to see how sharp they are. Yes. Then the right atrium border, the heart, the left atrium border, the pulmonary markings. Yes, so the things that I've mentioned are actually very important, so please take note of them. Let's move. So let's talk about some common alveolar patterns. So one thing you need to take note is the type and homogeneity of the opacity. So what does that mean? So if you look at a normal chest x-ray, you're going to see that the opacities are usually homogeneous. They're actually similar, like you can see the same pattern on both lungs. So that's what is the type and homogeneity of the opacity. Then to the silhouette sign. So what's that? So that's basically seeing the outline of tissues. So this is the silhouette sign, the cardiac silhouette. This is the right border. This is the left. So this is what the silhouette sign is. So you'll notice in some lung pathologies, the silhouette sign will be obliterated. And now we'll talk about air bronchograms. So what are air bronchograms? So usually if we look at the lung, we know that the lung is filled with air, right? The alveoli are filled with air. Then we also have bronchi that also have air in them. So due to which you are not usually able to appreciate the bronchus because the bronchus have air and the alveoli around them also have air. So what are air bronchograms? So these are basically the ability to see the bronchi when the surrounding alveoli are filled with fluid, such as edema or pus, but the bronchi remain clear filled with air. So that's what a air bronchogram is. I think we'll be able to appreciate that in one of our images. So yeah, basically the conditions we'll be talking about will be pneumonia, pulmonary tuberculosis, pneumothorax, pleural effusion, and atelectasis. Okay, so sorry, this slide was supposed to come before, but let's talk about it. Then the same we talked about alveolar patterns, there are also interstitial patterns. So there is linear, miliary, reticular nodular, honeycomb, and nodular. So linear pattern is seen as curly A, B, and C lines. Curly B lines are normally seen in congestive cardiac failure, interstitial pulmonary edema, lymphangitis, carcinomatosis. Miliary pattern is seen in TB. Reticular nodule is seen in TB, silicosis, rheumatoid lung disease. Honeycomb patterns are seen in fibrosing alveolitis, bronchiectasis, and nodular patterns are seen in tuberculosis, pulmonary edema, sarcoidosis. So the first condition we'll start with is pneumonia. So what is pneumonia? Pneumonia includes an inflammatory condition of the lung parenchyma in which some or all of the alveoli are filled with exudate, which is basically fluid and blood cells. So pneumonia is classified into lobar pneumonia and bronchopneumonia. So what are the common radiological findings in lobar pneumonia? So you are going to see homogeneous lung opacification, which is limited by fissures. The affected lobe of the lung retains its volume. And one thing you need to take note is in children, occasionally you may see rounded consolidation with ill-defined margins. So you're going to see round cavities. So sometimes a person might start suspecting that this may be a cancer, but no. So once you give them antibiotics, so this spontaneous resolution. Then it often shows air bronchograms. Cavitation is very unlikely, however, it may be present. Pneumonic effusions are fairly common and empyema not so frequently. So let's look at X-ray. So one thing we need to take note is, are you able to see the homogeneous opacifications? Yes, so immediately you see that you can already start thinking of pneumonia. And you're able to see the affected lobe, it has still retained its volume. So this is why I said that in children sometimes you may see a rounded mass maybe here, which a person might start suspecting it's cancer, but it's not. That's how sometimes it may present in children. Then often shows air bronchograms. In this image it's not so clear, but I'll show you in the next image. So basically if they ask you what do you see, what are the common patterns, so you should be able to see homogeneous opacifications that are limited by fishes, okay? Then you can also put the often show air bronchograms, and you can put that cavitation is very unlikely, however it may be present. So yeah, so let's look at this pneumonia. So this left upper lobe consolidation, this density in the left upper lung field, this loss of ciliate and left heart margin. I hope you're able to see there's no left heart margin here, there's no ciliate sign. Then there's density in the projection of the left upper lobe. Sorry, I forgot to put that image here. And you should be able to see air bronchograms. Yeah, these are air bronchograms, very clear. So normally we're not able to see them because even the lung is filled with air. But here, so I hope we've appreciated the air bronchograms. Then let's look at radiographic findings of bronchopneumonia. So you see heterogeneous opacities in a scattered multifocal and bilateral. If you remember in global pneumonia, we said that they're homogeneous opacities. In bronchopneumonia, they're heterogeneous opacities. And they ask in a scattered multifocal and bilateral distribution. However, one thing you need to note is with worsening of disease, opacities may become more homogeneous. Air bronchograms are usually absent, and pleural effusion or empyema, cavitation, pneumothorax, and atelectasis, they're all very common in bronchopneumonia. So let's look at the diagram here. So first thing you need to take note is their heterogeneous opacities here. Are you able to see this? Yeah. So these are heterogeneous opacities, and you can notice that they're present bilaterally. Then you're unable to appreciate any air bronchogram here. And then one thing we said is that with pleural effusion or empyema, cavitation, pneumothorax, and atelectasis are common. So you shouldn't be surprised if you see a bronchopneumonia as well as a pleural effusion. Okay. Then one thing you need to know is pneumonia caused by Staphylococcus is quite common in children, and in those cases, you may be able to notice pneumatocysts. So, what are pneumatocysts? These are basically air-filled pockets, air-filled cavities that may be present more commonly in children. So, that's all about bronchopneumonia. Let's go to TB.